Hi, we're at the 2018 American Society of Hematology meeting in San Diego, California. It's my pleasure this year to present on behalf of my co-authors the standard of care outcomes for patients who underwent axi-cel CAR T-cell therapy following its approval in the United States last fall. This was a retrospective analysis with data utilized from 17 U.S. academic centers, and the intention was to analyze the outcomes for all patients that underwent leukapheresis for the intention to manufacture standard of care axi-cel. We had a cutoff date of August 31st, 2018. Across the 17 centers, we collected data on 295 patients, and we provided the comparison to ZUMA-1 because I think there's still growing interest to see if we can reproduce the findings of this prospective study. So among our 295 patients, 274 were successfully infused with CAR T-cell, which was about 93%, which compared favorably to the prospective study. We also described the baseline characteristics of our patients, again, compared quite favorably. We had about 75% of patients that were relapsed refractory patients and had failed at least 3 prior lines of therapy. In regards to the baseline characteristics in terms of which patients would have been eligible for the prospective study, about 43% of patients would have failed to meet the eligibility criteria. Some of the most common reasons were cytopenias. Some patients had had prior CD19-directed therapy. Some patients had undergone prior allogeneic stem cell transplant. We then reported the outcomes at day 30 and day 90, and this was a relatively short follow-up of 3.9 months. But what we demonstrated is that the overall response rate at day 90 was approximately 80%, and about 47% of patients had achieved a CR. We then looked at the best responses by day 90, and that also compared very favorably with the ZUMA-1 data that had been presented with a 15.4-month follow-up. We also explored sort of predictors of ongoing response at CR 90 days. And interestingly, disease-specific characteristics such as lymphoma subtype, whether they had double hit, triple hit features, whether they required tocilizumab, steroids, or ICU care did not predict for ongoing response. In regards to safety, we also found very comparable findings in terms of the grade 3 or higher cytokine release syndrome or neurotoxicity. So approximately 2/3 of patients did experience grade 3 or higher neurotoxicity, and 1/3 ended up requiring ICU care. We had 7 patients that died as a result of non-relapse mortality, 5 of which included infection. There was 1 patient with HLH and 1 with cerebral edema. There was a higher incidence of corticosteroid and tocilizumab use, which also demonstrates potential shift to earlier intervention in terms of cytokine release syndrome and neurotoxicity in compared to the prospective study. Again, with relatively short follow-up, we did report on the PFS. We had a median of 6.18 months, and the 6-month overall survival estimate was 72%, again, which compares favorably to the prospective data. So to summarize, we had 43% of patients that would have not met eligibility for ZUMA-1, but despite that, the safety and efficacy appears to be very comparable.